So good morning or good afternoon to around the world. A warm welcome to our webinar session today that we again dedicate to the topic of fetal cardiac imaging using MRI. Again, this webinar will be recorded. And the session today is special, not only because it is the last session of this year, but also because we have an external moderator today next to Fabian and myself. I am very happy to welcome Malenka Bissell from University of Leeds. Malenka is a well-known pediatric cardiologist in the field of fetal cardiac MRI, and Malenka will lead us through this session today. And again, for those especially that might attend our webinar for the first time today, I would like to highlight that it is our aim with this webinar to build a community and to offer a platform for networking and for exchange. You are all very welcome to talk and to discuss during this webinar. Therefore, please just simply raise your finger to show us that you want to talk, or you can paste your questions directly into the chat or also use the Q&A function. And as we have learned that training and education, especially in the last year, we have learned that training and education seems to be really the key for a successful fetal cardiac MRI scan. You will now find a training section on our website. You will find it in our members area under customer support. And this is for any SmartSync user who has already participated in our basic safety and function training. So you will find there different training videos that support you with setting up SmartSync, planning and adapting the sequences. I guess this will be very helpful for you. Please make use of that. And before we jump now to our webinar session today, let us just quickly review our whole series in 2024. We have started our series in January this year with a kickoff session where, among other topics, initial reference values have been presented, motion correction strategies have been discussed, and also the 3D black blood processing tool has been introduced. In our spring session then in March, we have focused on clinical cases in fetal CMR while dedicating the whole process of scanning. And we were discussing challenges during examination and presenting the choices of sequences. We then had our summer session in June, and where we focused on the clinical impact of fetal cardiac MRI. And we have discussed how to achieve optimal image quality and motion compensated 3D reconstruction techniques. In September, in our autumn session, that was dedicated to only clinical cases where fetal cardiac MR has been important for clinical decision-making. And all those sessions have been recorded as well and are available on our website. And you are welcome to watch them. All right, having said that, we will focus on our session today at the end of the year, where we want to take a look into the future and we want to answer the question, what functional application can bring additional clinical value also beyond structural anatomy? And I'm very glad to welcome our four speakers today, which is Julian Luetkens from University Hospital Bonn, which is Alexander Barker from Children's Hospital Colorado. We have Eric Schrauben from Amsterdam UMC in the Netherlands, and we have Joshua van Ameron from Sick Kids Toronto from the US. And yeah, I'm very glad to welcome you all. And we will start the session with Julian. He is radiologist and director of radiology department, and Julian will focus on myocardial strain analysis in CHDs and on the value of it. So Julian, you are welcome to share your slides.
Yeah. So welcome everybody. I hope you can see my slide now.
Yes, we can.
Perfect. So welcome to the winter series of this webinar. So my talk is about myocardial strain in congenital heart disease, especially in fetal cardiac MRI. So these are my disclosures. And just as a background, so what are we looking at with myocardial strain? So myocardial strain is a tissue tracking technique for a quantitative evaluation of myocardial motion and deformation. And clinically, it's mostly used within the three directions of the left ventricle: the longitudinal direction, the radial direction, and the circumferential strain is also mostly derived. And as you can see over here in this M mode image, is that there is a feature which is tracked throughout the cardiac cycle, and also on this 2D images you can see how feature tracking works, that during diastole and systole a specific point is tracked throughout the cardiac cycle. We now have the possibility to do the direct cardiac gating with Doppler ultrasound, and this enables us the use of conventional CNA imaging in clinical routine. And what we do here in Bonn and also in other centers, we at least try to image some axial planes. And fortunately, in the fetus, because the lungs are not inflated, the axial plane on the ventricular level corresponds to a four-chamber view. And this is also the four-chamber view is the view which is mostly used for myocardial strain analysis. And if you look at the literature, you can see that there are, this year were 4 papers and one editorial published about feature tracking myocardial strain in the fetus, because it gives you more information maybe about cardiac function in healthy physiology and also in congenital heart disease. And I will show you some results of this paper, and then also dive a little bit deeper in one of the paper of our group, and I will explain how we did fetal strain imaging at our institution. This is the first paper. It's from the group from Alex Barker, where they looked at healthy fetuses, and they also did a strain analysis in the four-chamber view with the circle tool. And what they found, in these normal fetuses, that the longitudinal strain was minus 19% in these cases. And strain was derived from a single plane from the axial stack. This is another paper from Hamburg, where they also did myocardial strain assessment with feature tracking in 38 fetuses, and in this group there were also 23 fetuses with congenital heart disease, although congenital heart disease were mostly septal defects and also valve anomalies. And strain assessment was successful in this study in 88% of cases. And what they found in this study, that they found higher values of strain in controls compared to congenital heart disease, for example, in left ventricular global longitudinal strain, in right ventricular global longitudinal strain, and also in strain right. And what is interesting, that the normal strain value in this paper was also around minus 19%. And this is the paper from our group, where we also evaluated feature tracking strain in fetuses with congenital heart disease. And what we try to do is to evaluate strain in different subtypes of congenital heart disease, to find out if there might be a difference between different subtypes of CHD. And this was a retrospective analysis of a prospectively enrolled cohort. And this is something about the method we used. So our field strength study was a 3 Tesla magnet, and we used a normal anterior and also posterior table coil for signal reception. Gating was done with Doppler ultrasound, and the mouse women we scanned in left lateral positioning. And the sequence we used for strain analysis was standard segmented 2D CNA imaging in the four-chamber view orientation. And these are the scan parameters we used in our study. And what is maybe interesting is that the temporal resolution, the measured temporal resolution, the acquisition time was 25 milliseconds, and this was interpolated due to an average of 25 reconstructed phases to 17.5 milliseconds. So this is the temporal resolution we use in our study for feature tracking strain analysis. And what kind of software did we use in our study? We did not use the Circle software, but we used the software from Segment. And this software model was optimized for fetal application, that we can also use high-resolution data within the software, and you are also able to track smaller objects. However, the tracking algorithm, it remained unchanged from the non-fetal version, which you can also buy. And what kinds of parameters you can get out of this software? You can get parameters like right ventricular and left ventricular global longitudinal strain. You can get the radial strain, and you can also get some information about the longitudinal systolic strain rate. And we included 88 fetuses in our study, and we had to exclude 26 scans because we wanted to group different CHD categories, and we had all very large number of CHD entities which were only occurred once in our studies. So we had to exclude 26 scans, and we were left with 62 scans, and we also had to exclude 2 scans due to insufficient image quality. And we finally were able to include 60 fetuses in our study. And strain assessment was quite successful in the study, so we could derive from all ventricles, so left and right ventricle, strain assessment was successful in 94% of cases. So these are the results, and these are the clinical characteristics of our study population. We had a control group, and which were healthy, and we also had a group with congenital heart disease. As you can see over here, we had 6 groups available, which ranged from DTGA to pulmonary valve stenosis and atresia. And gestational age in our group was around 250 days, which is around 34-35 weeks. So what are the results? So interestingly, we could observe reduced left ventricular longitudinal strain compared to controls, especially in hypoplastic left heart syndrome and in right ventricular dominant AVSD. And we found also higher longitudinal strain in compared to controls in patients with COAC. So these patients or these fetuses had a higher global longitudinal strain compared to controls. And we also found a reduced right ventricular longitudinal strain in comparison to controls in fetuses with their pulmonary stenosis, which you can see over here. In these cases, the right ventricular longitudinal strain was reduced. And again, the mean value for normal fetuses was for the left ventricular longitudinal strain was around minus 19%. And these are group differences between cases with congenital heart disease and controls. And what you can see here is that there aren't any significant differences in cases with congenital heart disease and controls if you all merge these cases. But also what you can also see here in this plotted graph is that there are distinct differences in strain parameters, especially if you look at some subgroups. For example, you can see over here in orange, these are cases with hypoplastic left heart syndrome. They have a decreased left ventricular global longitudinal strain. And patients or fetuses with a COAC, they had an increased left ventricular global longitudinal strain. So there might be some information in strain patterns to differentiate between different kinds of CHD. And this is just to show you the interreader and interreader reproducibility, which was good in our study, and also the ICC values, they were good or very good. And this is a clinical example of a fetus with a coarctation of the aorta. And you can see here also in this scene image that the right ventricle is enlarged in this fetus. And you can see here the track contours of the left ventricle and the right ventricle and diastole and systole. And what was the case here was that the strain, the left ventricular strain, global longitudinal left ventricular strain was minus 25% in this case. Again, normal is minus 19%, so it is increased. And this might be due to an increased afterload due to the corac and possibly also the coexisting aortic stenosis. So in conclusion, I want to say that fetal cardiac MRI has the potential to become an adjunct to echocardiography for comprehensive assessment of congenital heart disease, and recent technical developments support its integration into clinical practice. And fetal myocardial strain analysis using cardiac MRI-based feature tracking, it's feasible. This was shown this year by several papers, and it has a high success rate. And there's also some optimized software already available. And we also could show that biventricular strain differences are present across a variety of congenital heart disease. And yeah, it's an active field of research. And overall, fetal cardiac MRI might be a new frontier for cardiac MRI. And so I want to encourage everybody to start his or her fetal cardiac MRI program today. So thank you very much.
Thank you
very much.
That was a fantastic talk. I've got a couple of questions to start. Oh, we've just lost him.
Oh,
He's back.
He's back. You're back.
I guess so. Hopefully. Yeah, he's back.
You were hiding. You were hiding from my questions. That's what you were doing, Julian.
I was hiding. So there were two red buttons. The one was leave the chat, and the other one was
leave the room. Leave the room.
Those,
right.
The wrong button.
So we've been trying to do fetal strain. Disclaimer: we're on Siemens, so I think our cine imaging is less crisp than you guys. But how much of your strain is actually manual adjustment, and how much is automatically run? Do you need to adjust a lot, or does it? Where I mean, I know you mentioned some adjustments were made by the software company, I assume, but do you still manually adjust or no?
So it depends, of course, what kind of image quality you have, and if you have a quite good delineation of the endocardial border, it's you don't have to adjust many phases manually, and we always first make the contours in the end diastolic image, and then propagate it automatically through the software throughout the cardiac cycle. And in most cases it worked well. In some other cases we had also, of course, to adjust a lot of points. And in our paper we had a cut when we needed to more than 10 adjustments per ventricle. We excluded this scene image. So, but the successful rate was high with, I think, 94%. So yeah, it depends on the image quality and also of the myocardial edge definition. Yeah.
Joshua's got a question before I could get my second one in. Go ahead, Joshua.
I was wondering about spatial temporal resolution and strain measurements. And I was trying to look it up just now. I couldn't find it, but like with a lot of things in fetal CMR, we're at the sort of limits of guideline spatial temporal resolution. Can you comment on what impact that will have for strain measurements, and if indeed these are falling at those limits or below, and whether that's much consequence for potential clinical utility?
Of course. So temporal resolution, you need for an accurate strain estimation, you need a high temporal resolution. Yeah. So in our study, we had a average temporal resolution of 17 milliseconds, which is far lower than in adults, for example, when you do feature tracking strain, yeah, on cardiac MRI. In echo, you have a much higher temporal resolution, and but of course, also in the fetuses, we have a high heart rate. So the average heart rate in our cohort was around 140 beats per minute. So although the temporal resolution is good for MRI, yeah, you still have only 25 images, and you might, of course, miss the peak strain value, yeah, if you are limited in your temporal resolution. And this also answers your question, the second question. If you really want to use it as a clinical tool, you must to be sure that you really derive the peak strain, yeah, if you want to use it as a biomarker. And this is something, yeah, we don't know yet, I would say, if it's enough to really derive the peak strain. You have to do some comparison studies, maybe also with echo strain, but we don't know yet. No. But of course, temporal resolution is a major problem. No.
I think in the interest of time, we probably need to move on with the next presenter. Is that right? So our next presenter. Yep. Are you doing? Go ahead. Go ahead.
Yeah, we jump to Alex Barker. Alex is Associate Professor of Radiology, and he's going to talk about establishing CMR normal values to aid diagnosis. Thank you, Alex. It's your platform.
Great. I hope everybody can see my slides. Okay, well, thanks for the opportunity to talk about our effort. And I think just to take a step back here, all our talks are very complimentary when I was looking at the agenda. So I'm pretty excited to make some commentary that hopefully will inform and carry over into some of the other talks. With that said, I'm going to revisit our efforts here because fetal CMR is so new to establish what is normal with actual MRI, fetal CMR values. It's difficult to say because most of the echo or most of the normative values that are reported for cardiac function are from echo. And so that kind of steps into, if my screen will advance here just a second. Really, the purpose of my talk today is to both go back and revisit some of what I talked about back in January concerning kind of our efforts to establish what is normal for third trimester ventricular volumes, function, and strain, which also is encouraging Josh because we're getting the same strain values when it comes to normative measurements, at least. So I'm encouraged a little bit by that. Secondly, I'm going to touch on another paper that we just recently put out looking at establishing the reliability and repeatability of our flow measurements with 4D flow. I think it's all very early, and of course, there's a lot to learn as we move forward, but I think we do need to start planting a flag in terms of what is normal cardiac function and flow that we expect in the third trimester fetus. So I'll talk about these two papers today. First, just jumping right into the first paper that we published already last year, where because most normative values, as I mentioned, are established from echo studies, and there's a number of geometric and coverage limitations. When we use echo, I'm showing here on the right kind of the Simpson pi-plane assumptions that are used for establishing volumes, and you can appreciate that there may be some assumptions that are necessary to compute a LV volume. So because of this, we really do need to establish what is normal using our modality, that is fetal CMR, because it's crucial to identify what is abnormal structure and development in these babies. So this study was a single center prospective study focused on a very tight gestational age of 34 weeks plus or minus a week. That was intentional. That's really our sweet spot. The imaging was pretty standard that we did here, except I will mention that we did a localizer that covered the entire fetus so that we could compute fetal weight from the fetal volume. I'll talk a little bit about this later, but we do feel that it's pretty important for normalization purposes, just like we normalize by BSA in adults. The sequences that we used started with an axial stack, then we went to 2-chamber, 4-chamber, and short-axis imaging, usually over-prescribing the slices by 10 to 14, and then stopping our acquisition when we get the coverage we need because of the fetal motion. We used off-the-shelf Circles CVI ventricular volume calculations, using kind of anything the same approach we use in adults and adolescents and neonates to compute volumes. What we did that was not standard for fetal CMR, or not standard for CMR in general, was we needed to compare our measurements to echo studies. And echo studies also do a number of two-dimensional lengths, where we show some of those dimensional measurements here in this graphic. And this was really to validate that what we were getting with CMR kind of corresponded to what we see with echo. We performed inter-observer reliability and using Bland-Altman and interclass correlation. Julian did me a favor. He already showed this table, thank goodness. But the good news is our dimensions matched quite well when we looked at echo by lengths. You can see we're centered around kind of 0 with our z-scores. And again, Josh, our longitudinal strains match very nicely with Julian's. He got 18.9, I believe, for his LV longitudinal strain. We got 19. This also corresponds nicely with echo. So I'm encouraged a little bit by that. Of course, temporal spatial resolution is very important to consider. Secondly, when we look at volumes, and this is going to Josh, your site, we don't really have a gold standard, but luckily there's animal studies as well as your colleagues who computed kind of the contribution of the left heart and the right heart to the combined cardiac output using 2D phase contrast. And with our volumes, we were also able to compute our cardiac output as a percentage of the combined cardiac output. And we found, and we were encouraged, that our numbers matched up very well with that 2D phase contrast study already done almost 10 years ago by your site. This was encouraging, but what about our absolute volumes? Well, when we look at echo in terms of ventricular volumes, they were way higher for CMR, anywhere from 50 to 100% higher. This was initially concerning to me, but our cardiologists who do echo all day long said, yeah, that's not too surprising. We do a lot of assumptions. This is kind of showing some of the biplane assumptions used for the Simpson's biplane calculation for volume. And you can appreciate kind of foreshortening of the apex, assumptions used for the basal slice or major and minor axes when computing the volume. So while we're not completely alarmed because of the next slide that I'm going to show, I think we do want to confirm some of these results with more multi-center studies. But I was extremely confident or happy to find in an also recent paper in newborns who are effectively 40 weeks gestational age or 32-hour-olds, that when we look at indexed values by weight, and this goes back to my initial comment, while our absolute volumes, because our fetuses are smaller, or 35-week gestational age fetuses compared to 40-week gestational age, they're smaller by about 1 to 3 mils. Our indexed values by weight are absolutely right on point. And so we're very encouraged that what we're seeing is real for both RV and LV. So I just have a slide here on the importance that we think for indexing, and we've had a protocol, kind of a fast 3D FFV that allows us to get fetal weight, because we can appreciate even at a gestational age of 38 weeks, the range can be 2 kilograms between a normal fetus. So we're working very hard to kind of automate this and come up with a facile way to compute weight for indexing, which I hope to report on later. I don't have much time to go into this other than to say that, unsurprisingly, most lengths did not agree well between observers, and volumes performed better. So that's good for fetal CMR. You can see some challenges with getting good agreement in systolic volumes, particularly in the right ventricle, also for ejection fraction. But otherwise, ICC was good across the board. Why is this important? Well, we think that it may be able to discriminate adverse events, for example, in congenital diaphragmatic hernia, where we're tracking in now 20, effectively 20 CDH cases, adverse events in terms of death or need for ECMO. We're finding good predictive capability of, for example, left ventricular global longitudinal strain. I think more work is needed to be done. But more importantly, it's a compelling idea that we can combine flow values with our anatomic measurements. And so this is one of our most recent papers where we wanted to establish the reliability by precision, internal consistency, and accuracy of our flow values that we're measuring with 4D flow. And I don't have a chance to talk about this in depth, but when it comes to conservation of mass, we're encouraged, although maybe there's a bit of an error, and we think this is due to motion. I hope Eric will talk about this in a bit. Our error, when you look at the isthmus and ductus added together and the contribution to the descending aorta, there's an error of about 19%. But I think we can reduce that with motion correction, and I think Eric will talk about that in a moment. Scan-rescan reliability is pretty good, centered along unity when we make our flow measurements. And this is all leading into the fact that we need to establish what's normal, because right now we're working in particular on coarctation diagnoses. And when we combine our anatomic measurements, say, for example, from slice to volume reconstruction for morphology and our 4D flow measurements, we're almost getting 100% accuracy in diagnosing whether or not a suspected coarctation at echo is actually a true coarctation. So it's very encouraging. This is kind of all new data that's coming out, and we look forward to kind of reporting on this very soon. So I'm out of time, but I just wanted to thank the whole team here. This was by no means an individual effort, and thank you for your time for allowing me to talk about this. Thanks.
Thank you very much, Alex. I'm still very impressed that you managed to get fetal volumes in so many fetuses. I would say for us, it probably only works about 50% of the time. So often we just get too much fetal motion throughout the stack. What do you do? Do you take more than one stack? Have you got any good tips of how to make it more reliable?
You know, that's a great question, Malenka. Sometimes we do need to require a specific slice of the stack because of motion. And if the baby does move, and I think this goes back to some of the success rates in Julian's study, where they were using just the axial 4-chamber view to compute strain. The more views you acquire, the more chance you have for the baby to move and for things to go wrong. I would venture to say in 80% of our cases, we get the short axis stacks. Now, our center may be a bit luckier. I don't know. We also are very careful about kind of the timing of our acquisition so that we don't wake up the baby when we get these stacks. But once you start doing the cine stacks with breath holds, you're going to wake the baby up. And it'll be interesting to see what other centers' experiences are. I would say 75 to 80% of the time we get the short axis stack. But it's a challenge. We do need to reacquire sometimes.
Yeah, I find it hardest when the fetal motion is actually sort of within your stack plane. So you suddenly, your basal slice is there 3 times. You're like, great, that clearly can't be right.
Yeah, no, I was actually just thinking about exactly that. Like 4 times in a row, you get the basal slice and you're like, okay, I got to move on. Sometimes you just have to call it. I think because we're doing these as pure research studies for the kind of reference value paper, we're lucky that we had the time to reacquire. I think we do need to think, what is a realistic clinical workflow? We can't sit there and keep trying to get that stack in a clinical workflow. Sometimes you have to move on.
Yeah, agreed. I'm just checking the chat, whether there are any other questions.
No, there are none.
Not so far, right?
No, well, we're going to talk a bit more about flow after the next session anyway, aren't we? Yeah, you've given us a nice teaser, so flow is my favorite topic to talk about, so probably good to move on, isn't it?
Sure. So we'll move on to Eric now. As he was already introduced by Malenka now, Eric is going to talk about 4D flow application, including motion compensation. So welcome, Eric. Happy to have you here.
Yes, thank you.
You can see your slides. Perfect.
Great. Okay, so hi everyone, and thanks to North for the invitation. Today I'd like to show a few examples, uses of fetal cardiac 4D flow as a functional application that I hope can add clinical value. And I also hope to convince you that motion correction or compensation will increase 4D flow's potential for future use. So I wanted to jump directly into a case, which is a 33-week gestational age fetus, where from echo there was an inconclusive transposition of the great arteries. 4D flow MRI with a 3x sense acceleration and smart sync gating was performed, and this resulted in about a 3-minute scan time. So from the magnitude and foot to head velocity images, we see pretty good signal with some maternal breathing artifact. And when we loaded this without segmentation directly into a dedicated 4D flow software, we can appreciate some blood flow patterns, but nothing really too specific to note. So then we have to go through and do careful segmentation on the phase contrast MR angiograms. And once we do that, we can start to see the value of 4D flow for anatomical assessment, including this elongation of the ascending aorta, which is indicative of TGA, and this caliber of the ascending aorta and descending aorta, which really rules out any interruption or coarctation. Now, if we load this segmentation into a 4D flow software, then we can get a more in-depth flow characteristic, including emitting particles from the ascending aorta, which then appear to reverse over this narrowed ductus arteriosus. So this results in a reverse diastolic ductal flow. And indeed here, the postnatal diagnosis was a TGA and pulmonary atresia. So 4D flow in this case did give us some complementary information, and we could confirm both of these. It's, however, important to note that we were pretty lucky or fortunate that there was near zero motion during this 3-minute scan. And one thing we do know for sure that both speakers have just talked about is that for scans over several minutes, some motion will occur. And so that's why in the past 18 months or so in Amsterdam, and in collaboration with Alex's group, we've been putting together this pipeline for motion correction for a 4D flow MRI, with the hopes of getting it more robust to motion. And so to do this, we use our in-house developed scanning acquisition, which is called PROUD, for prospective undersampling in multiple dimensions for 4D flow MRI, in which we can match the resolution and field of view to the sense accelerated scans. And we can kind of pseudo-randomly acquire around K-space in a free-running manner, where each point here is a readout that's time-stamped now for maternal respiration based on the bellows signal, and also fetal heartbeat based on the smart sync signal. And once we have this free-running acquisition, we can actually play with the data retrospectively in a number of different ways. And so the first thing that we do is retrospectively limit our data acquisition to maternal expiration to remove any maternal breathing artifacts. And then we take our data and sort it into consecutive frames of around 15 seconds that give us bins over time of the scan. So these are reconstructed now into phase contrast MR angiograms, where we can appreciate the motion of this descending aorta in the fetus throughout the scan. If we register these images together, we get pixel shifts in image space. We can apply them as a phase shift in K-space, which gives us a corrected K-space that we can now put directly into our compressed sensing reconstruction using the smart sync signal for cardiac gating. So we've done this a few times, or around 35 times at this point with the group in Denver. And this is an example of the effective motion correction, where before motion correction in a sagittal maximum intensity projection, we lose a lot of the signal, especially at this insertion of the aortic isthmus and ductus arteriosus into the descending aorta. You can appreciate that both on a sagittal and coronal view. While after motion correction, we can really nicely see the completion of this descending aorta, as well as recovering some of those smaller vessels here. So Reagan Tompkins, our PhD student, applied this motion correction pipeline to around 30 fetuses scanned by the group in Denver. And this paper was actually just accepted yesterday in MRM. So this is hot off the presses. And yeah, she was able to show that the PC MRA feature score from uncorrected to motion corrected increased significantly. But more importantly, and to what Alex was just presenting, the conservation of mass actually decreased quite a lot in our motion corrected data sets. So he reported around 20%. We had around 14% in our uncorrected data sets and around 5% in our motion corrected data sets. And this is actually a really important step forward because it gives us confidence that we are more robustly able to measure this distribution of blood flow inside of the fetus. And so the second clinical case I'd like to present uses this proud accelerated acquisition and motion correction pipeline in a 32-week gestational age fetus. In this case, echo noted a potential coarctation, and the 4D flow acquisition was performed with a target acceleration of 2.5 and took around 6 minutes. So over the 6 minutes, we definitely expect some motion to occur. And indeed, when we look at this maximum intensity projection of the PCMRA, we can see considerable noise as well as a complete loss of signal directly at the location where the suspected coarctation would be. So if we put this into the motion correction pipeline, here are the bulk motion bins over time, where again, each bin is around 15 seconds of data. And we can identify quite a bit of motion, including a few bins in the middle there, where we completely lose signal. So after registering these together, we can derive motion curves for correcting data, as well as a few of these bins where signal is lost that we can then just reject. So here's an example of the corrected data afterwards, where we can again nicely see this completion of the descending aorta, this portion that appears to be a narrow descending aorta at the insertion point. But we can also see some of these smaller vessels again, like this left subclavian artery, which is quite faint on this image, but trust me, it's there. We can again put this through some manual segmentation. And if we load that segmentation into our 4D flow software and emit streamlines from the ascending aorta and pulmonary artery, or the ductus arteriosus, then at peak systole, we can see there appears to be nice flow coming over this aortic isthmus, and at end systole, some flow going into the left subclavian. If we color code where these actually come from, we can see that this left subclavian flow actually is originating from this ductus arteriosus. So in this case, we actually have a reversed isthmus flow coming from the ductus arteriosus. So these are the two findings. We had a narrow descending aorta, which we could appreciate from the anatomical scan, the PCMRA segmentation, as well as a reversed negative blood flow in the aortic isthmus. And it's actually this reversed aortic isthmus flow that is kind of a hallmark of one of these true positive, it's one of these true positive hallmarks that David Lloyd and his colleagues were able to show in this paper in 2021 using 2D phase contrast. And indeed, the postnatal diagnosis here was a coarctation where the required intervention was an extended end-to-end anastomosis. So I hope that I've shown you that 4D flow can be complementary to anatomical scans and echo, and that it can be made more robust with this combination of a free-running acquisition and motion correction. I think there are quite a few needs in order to clinically adopt this, including removing the manual interaction to identify and correct or reject motion. And we hope to use the SmartSync device for this in the future. Yeah, this also requires quite some expertise in manual segmentation, so we hope to make that faster or more automated in the future. And of course, clinicians and technicians want to be able to see these images right after scanning to check image quality. So on the scanner, compressed sensing reconstructions will become important in the future. So thanks, and thanks to my collaborators, and happy to discuss this.
That is fantastic work, Eric. Really impressive pictures. My first question is, do you scan at 1.5 or do you scan at 3 Tesla?
Yeah, we scan at 3 Tesla.
Have you ever tried it at 1.5, or is it just a no-go?
If we had a 1.5 Tesla research scanner, we would be trying that, yes. I would prefer to do it at 1.5 Tesla.
Would you? Why is that? I'd be intrigued.
I think because there are many other anatomical scans that would benefit from 1.5 Tesla. So in order to do these 40 flow segmentations, you often would like to have something on the side that is a more true representative of the anatomy than a spoiled gradient echo image. But
yeah,
I understand your question. At 3T, we definitely get more potential for signal, especially in these 40 flow acquisitions. So it's a trade-off for sure.
Yeah, because I mean, we found 3T definitely way easier. 1.5, trying to get any flow in the arch without motion correction. Obviously, we don't have motion correction. It's just an impossibility.
Hmm.
But I agree. I think going forward, the majority of scans will be done on a 1.5 system. So if we do want 40 flow to become a mainstay, it does need to work at 1.5.
Yeah.
Alex, you're at 3 Tesla as well, aren't you, for your 40 flow?
Yeah, primarily because we have focused so much on 40 flow. We've had to make some sacrifices in our anatomic imaging. If we have a large mom or polyhydramnios, then we're going to 1.5T, right? We have kind of a threshold, but we go for 3T when we can because of the added benefit of ability to measure flow. But I mean, that's a lot of our research studies. Clinically, you have to have it work also at 1.5T.
Yeah. Do you get decent images at 1.5, or is it one of those lost hope?
I mean, we have reported on it. I'm not blown away by the image quality, signal to noise.
Yeah, no, same here. Really interesting stuff, Eric. Obviously, we want to all be able to use us as clinicians as quickly as possible with one button, and it all reconstructs automatically. At the moment, it's just one vendor that's available for. Is that right? That you're trialing it on?
That's correct. Yeah. So we work pretty exclusively with Philips scanners here, but in principle, the concept of everything here should be applicable across scanners. So I think actually Josh has quite some experience on both Siemens and Philips, and we would be able to talk a little bit more about what's possible between the two in terms of motion correction. But I will point out that the motion correction idea here is quite similar to a lot of the work that's come out of KCL and also Sick Kids in terms of first reconstructing kind of a motion resolved or dynamic data set to identify motion, and then correct the case-based data itself before doing your final reconstruction.
Well, I think that leads us very nicely into our last talk, Heidi, doesn't it? They're all seemingly introducing each other.
Yes, I agree. And let me correct myself, Joshua, Sick Kids Toronto from Canada, of course. Yeah, we are very happy to have you here today. And Joshua will present about 2D flow assessment of cardiovascular physiology. And yeah, we are really happy to listen to your talk. Thank you for being here.
Oh, happy to be here. Thank you for the invitation. So yeah, I'll present on some work that's a little bit less, I guess, hot off the press, stuff that's been done here over the last decade or so, with some of the newer stuff in here as well. And so I'll speak about 2D measurements of blood flow as well as blood oxygen saturation and looking at assessment of cardiovascular physiology then. Interestingly, none of this has actually been done utilizing the Doppler ultrasound device for gating, but it could be, and there might be a couple of places where that would definitely be an improvement. But none of this has actually been done with that. So I'll just start by introducing the sequences a little bit and their analysis, and then look at a couple of studies that we've done and some clinical cases that might highlight some utility there. So for the simpler measurement of blood flow using 2D phase contrast, not the 3D plus time that has been discussed in the last couple of talks, you would use the standard 2D phase contrast where the velocity is encoded into the phase of some image series. And this is the gold standard for cardiovascular postnatal flow measurements. And I've looked at some typical fetal acquisition parameters there. And so you can see the voxel size of 1.3 in plane. Importantly, I guess, scan duration is about 18 seconds for just through plane flow encoding. And the scan plane needs to be approximately perpendicular to the vessel. And that can take actually quite a bit of skill to set up. But when you get it, you can get measurements like this by first placing vessel contours onto the images and measuring the flow within those regions. And as Alex had highlighted, these are often indexed to the fetal weight, which comes from a separate scan, and that removes dependence on gestational age. And so you can see we've been able, with a Cartesian 2D phase contrast, been able to measure flow in a variety of vessels and as well as congenital heart disease fetuses, which I'll talk about in a couple of slides. In terms of measuring the blood oxygen saturation, uses a combination of magnetization prepared steady state food procession sequences, both a T2 prepared and a T1 moly. These essentially have a magnetization preparation in front of a single shot steady state food procession readout. Slightly larger voxels, still approximately 13 to 20 millisecond, 13 to 20 second scan durations, but individual images themselves are required within less than 1 second. And that's important for motion robustness. So you get a series of images with different preparations or inversions, and then you can, to estimate the T2 and T1, fit the mean signal within a region of interest that you can move around from image to image to adapt for the movement, and then estimate the T2 or T1 from that fit. And then some nice work from Sean Portman here. The combination of T1 and T2 can then, by an analytic solution of this sort of complex relationship between T1 and T2 and hematocrit and oxygen saturation, can give you those values. So a single T1 measurement somewhere in a vessel along with another T2 can give you hematocrit, and then you can use that to then measure blood oxygen in other vessels, because that won't change much as far as I understand. So this is a paper from a couple of years ago now, where we had updated some of those measurements in sort of healthy normal controls, as well as a good number of late gestational cyanotic congenital heart disease fetuses. This might look a little bit small, but hopefully you can generally appreciate that there are flows along the top here and oxygen saturations along the bottom. In a variety of populations, but normal as well as hypoplastic left heart, transposition of great arteries, physiology of flow, Epstein's anomaly, and have I got that right? Tricuspid atresia. And so you can see that in hypoplastic left heart, all the flow is coming through the one side of the heart, so on. Superior vena cava flow is actually fairly well preserved in most congenital heart disease. It drops in Epstein's anomaly, and so on. And this can be used to give a general sense of how flow distribution and oxygen transport are modified in this congenital heart disease. All of this was done using a Cartesian phase contrast acquisition and the oximetry sequences that I discussed. As has been highlighted a couple times now, though, motion is going to be one of the major challenges here. And what we're looking at here is sort of one of these real-time image series that Eric had spoken of. And what you can see is there is all kinds of movement happening, fairly benign, and then at some point you have quite a bit of fetal movement. And if you aren't accounting for that, then that's going to end up in blur or artifact within your reconstructed images. For flow, while it's time consuming, it's actually fairly reliable to look at image quality and sort of screen for motion artifact, and then sort of a visual assessment and repeat the measurements as much as it can be annoying to sort of find that vessel again. For oximetry, you do have sort of these images that are acquired in less than a second, and hopefully most of them are still usable. And the vessel you're interested in remains generally in plane, and you can sort of move that region of interest. However, it is noteworthy that pulse type flow and other factors can lead to uncertainty in the T2 and T1 measurements. And actually, the T2 and T1 that we have measured has been using an ungated sequence. So Now that we actually do have the device here and have medical clearance to use it, that might be one area where we can sort of improve on the, reduce the uncertainty of the T2 and T1 measurements there. And so what we've been doing in terms of the flow measurements more recently is employing a golden angle radial acquisition rather than a Cartesian. The impact that has is it allows us to do motion correction in plane, do some data rejection through plane, and you can see just how much sharper the vessels end up. And what you can see here is that in simulated in-plane motion, even for large degrees of motion, you can see that the Cartesian and the golden angle radial have errors in terms of mean flow and peak flows. But once you apply motion correction to it, you actually recover or reduce most of that error. And so this is how we've been doing our flow measurements more recently. So a couple applications here in terms of using the flow measurements to monitor for intervention. This has been done looking at flows in hypoplastic left heart before and after a fetal atrial septal stent. And in those cases, you can see the pulmonary blood flow increasing quite a bit with the insertion of that stent to allow blood to stream over to the hypoplastic left side. And then in Epstein's anomaly, which can be quite detrimental, when there's a circular shunt, you sort of have this blood flow that continuously loops around and doesn't actually go to the rest of the circulation. But looking at the flow in the pectus arteriosus and the SVC before and after application of a non-steroidal anti-inflammatory drug, you can see that we've recovered SVC flow, which is going to be a surrogate for blood that's going to the brain, and this sort of reverse flow through the ductus arteriosus has been greatly reduced. And so one more, a bit more recent, we had a TGA case, and in this one, the MRI findings were suggestive of a restriction at the atrial septum, which would inform intervention. This was declined in utero, but it did allow for delivery planning. So I'll highlight here first. In TGAs, there's going to be flow typically across the foraminal valley. In this case, it was very reduced, but there's quite a bit of pulmonary blood flow happening still. And the other thing that was happening is you do still have higher saturation on the left side typically than the right in the TGA case. However, in this one is higher on the right side. A little bit, but all of these things seem to indicate that there's a restriction at the atrial septum, which would suggest doing some sort of intervention. This was planned for at the time of delivery in case it was needed. So all the teams were on hand. Prostaglandin was deployed, but there was still low oxygen saturation. So life support was applied. There's an urgent balloon subtostomy done, and then later an atrial switch. But having that information available allowed for that sort of elaborate delivery planning that might not have been possible otherwise. And so with that, there's a good number of people that have been involved over the years. Missing from this image here is actually Eric himself. So certainly acknowledge all of those and the funding agencies. Thanks.
Thank you, Josh. Thanks a lot.
Any questions? Do put them into the chat or the question and answer if you don't want to answer them. Josh, I find it really hard to do 2D flow. I find it okay to do the descending aorta, but I think ascending, actually, sometimes the ascending aorta and the MPA seem to be the hardest to do. I mean, sometimes we don't even try to differentiate which one is which until later and just kind of hope we've got each vessel. What do you do in order to achieve that?
what would I do? I would probably build an AI to do the scan plane prescriptions, or utilize something from King's. However, we have fantastic techs here, and Mike Sieb is great at doing these prescriptions. It does seem to be a bit of an art, and I think that might have limited some of the uptake. But I mean, come for a visit and see how it's done would be one way to do it. Some of the there are some reference guides that have been put out that Mike had put together with a lot of these sort of cross-sectional planes indicating where how to do that planning. I don't do that sort of hands-on scanning myself, so I haven't got up to speed with that. And whenever I've come close to it, I'm similar. Like I kind of get some basic ones, and then the more complicated ones, no, not a chance.
And I think it's a bit of a leading question back to the previous topic, right? Because I generally think 2D flow is really hard. Is that really where we're going to be heading in the future, or are we just going to pack it in and go for 4D flow? Because then we don't need to worry where all these individual vessels are. We acquire the 4D flow and we'll figure it out afterwards once the fetus is off the scanner in 3D. But then, of course, we come back to that discussion. Can we even do 4D flow at 1.5? So what are your thoughts, and the other panelists, if you want to kind of add in as well, what your thoughts are? Where are we heading in the theme of future directions of our topic?
I can start on that. I think low prescription complexity and redundant motion robust acquisition is the way to go. That's, I mean, just based on my own background, being non-clinical, but also just what I've seen work quite well. You know, in the fetal brain, for example.
Yeah.
Sort of peppering the region of interest with lots of images, and then putting things together after the fact, or even with what we're doing with radial phase contrast acquisitions, where we can tease out the motion that has happened and do some data rejection and so on. For flow measurements, a direct 4D flow acquisition is really appealing, especially if it is motion robust. We have done some work here, data, and I think Eric was involved in this as well, had at one point in time looked at doing 2D phase contrast measurements and then using a slice to volume type framework to put them back together. And that remains appealing in terms of sort of leveraging a bit of the best of both worlds potentially, but huge computation complexity. So that's a bit of a trade-off.
Yeah.
Yeah, and I would just add, I think that we won't be abandoning 2D flow anytime soon, but as Josh suggests, it could be possible to have multiple images or slice locations acquired within one stack. I think the group in Denver is already doing this, where they have a prescription and then acquire just the next slice up from there, hoping that between one of those two, something will be usable, because you do expect some motion to happen. I think it's difficult. I agree that overall the best approach going forward will definitely be placing a box around the heart and finding a good way to know when motion is happening, finding a good way to correct that motion, and measure everything much later retrospectively. But of course, much later is not always soon enough.
Yeah, if I can add on to that, I think I know we're out of time, so I'll be quick. Malenka, I'm somewhere between you and Josh. Like, we could never get some of the pulmonary flows, but we can always get the descending aorta, the umbilical vein. Otherwise, we go ahead and try the 2D flows, and we don't spend too much time if we're not getting it, and then we do a 4D flow.
And I think that's a really nice summary, isn't it? Just because it's possible doesn't mean it's easy. It doesn't always work in every fetus. Just because you conquered it in one doesn't mean it's going to work in the next one on the table. So it's all very much work in progress, but some really, really exciting stuff up on the horizon.
It's true. Malenka, thank you. That was a good, or thank you all. That was a very good end, I would say, a good summary. Yeah, thank you to Julian. Thank you to Alex. Thank you, Eric. And thank you, Joshua, for your contribution here. Thanks, Malenka, for moderating and taking over the Q&A. We would also like to thank the Fetal Heart Society and the SCMR for their support, for the good cooperation during the last years, and also for the future. And last but not least, we would like to see you again next year. Very likely we'll have a webinar series 3 in 2025. And with that, we'd like to end the session. And yeah, we, North Medical, wish you a happy new year and a good Christmas time. Thank you for your attendance and your support.
Thanks so much, everyone.
Thank you.
Thank you, everybody. Bye-bye.
Thank you, everybody. Bye-bye.